that you can see that there is a large amount of thickened interstitium visible, mostly on the right side, but certainly present bilaterally. She had a past medical history of scleroderma that she'd had for the past 10 years and had been on disease-modifying agents. This is her CT scan, and on the scan, these are the lung windows of a high-resolution scan. You can see that there are areas of cystic change that look very much like a honeycomb, and that is what this is described as honeycomb fibrotic end-stage lung. This is a biopsy that is representative and not from this patient, and here you can see that these are the honeycomb cysts that are lined now by metaplastic epithelium. There's a small section of relatively preserved lung down there, and there are areas where the interstitium is widened by collagen deposition. So this is the end stage of systemic sclerosis in the lung. When we're going to speak about the pulmonary manifestations, what I'd like to do is speak about how commonly is this problem encountered, a few bits about diagnosis, how they present clinically, and I'd like to end with a few illustrative cases. I'm sorry I won't deal with management, and I think that would just be too much time. I was going to find out if there was any literature from this part of the world about the prevalence of pulmonary disease in the various connective tissue diseases, and this is the first thing that I found, or actually the best thing that I found. This is from our neighbors next door. This is a descriptive study of 195 patients that looked at people with various connective tissue diseases who came in with respiratory symptoms to a rheumatology practice. What they found was that abnormal pulmonary function tests were available in almost 100% of people with mixed connective tissue disease, 89% of people who had rheumatoid arthritis, 84% with systemic sclerosis or scleroderma, and 30% of people with lupus. When they did high-resolution CT scans on them, they found that 78% had reticular nodular lesions, 15% had pleural effusions, 14% had honeycomb change, and 9% had bronchiectasis. The most common disease that was found was pulmonary arterial hypertension. Most of the people who had it were those who had scleroderma, a mixed connective tissue disease. And the second most common one was the interstitial lung disease, of which most people with scleroderma and about 50% of people with rheumatoid arthritis had it. So this is something that you will see commonly in your practice. I found this very interesting. This is data from 3 separate studies that looked at the prevalence of interstitial lung disease in scleroderma and in rheumatoid arthritis. In people who had autopsy studies available, they found that over 70 to 100% did have pathological evidence of interstitial lung disease. In people who had pulmonary function studies available, they found that almost 90% of people with scleroderma will have some abnormality. And only those who had X-rays or high-res CTs, they found that between 25 to 65% of patients with scleroderma will have abnormal studies. Rheumatoid arthritis is a little less frequent, but fairly prevalent, as you can see from the biopsy, the pulmonary function studies, and radiological findings. So even though your patients may not present with respiratory symptoms, they're likely to have some degree of pulmonary disease. Why is that? Well, most of patients with bad connective tissue disease and significant arthritis are weak because of catabolic conditions, because of muscle weakness. They are fatigued, and therefore they have impaired mobility. When they don't walk around as much and they don't climb stairs as much, they don't notice that they're short of breath when they're walking until there's significant loss of functional capacity. The first thing you might find a problem is when you do a routine chest X-ray, and it's important to recognize that occasionally the first manifestation of a systemic connective tissue disease will be when pulmonary symptoms develop or when the chest X-ray is done. So how would you diagnose it? Well, it's often suggested by the history, such as in our patient, a history of scleroderma, by the presence of chest X-ray or high-res CT scan findings. And if you make a clinical diagnosis, you need to have oral chest X-rays that show the classic progression of disease. You would have to rule out any other disease process or an occupational or an environmental exposure or a drug history exposure that could lead to similar changes. Sometimes when the pulmonary manifestations present first, we have to do a surgical lung biopsy to make the diagnosis. Radiologic detection of disease is best done by a high-resolution CT scan, and there's a number of findings that you can find. You can see ground glass opacification, which usually signifies the presence of an inflammatory exudate within alveoli. You can find the presence of interstitial thickening and honeycombing. You can see thin wall cysts, lymphadenopathy, or central lobar nodules, such as seen occasionally in sarcoidosis. You can see the presence of consolidation with air bronchograms, or the presence of what's called mosaic attenuation, which is due to air trapping within focal areas of the lung and associated bronchial wall thickening or a tree-in-bud appearance. In scleroderma, the majority of people with scleroderma may have findings of interstitial lung disease on a high-res CT, and of these people, only a lesser percentage will have this visible on chest X-ray. In the same way, in people with rheumatoid arthritis, a large majority will have findings on a high-res CT, even if they have a normal chest X-ray. Pulmonary function tests. Forgive me if I'm too basic here, but the first kind of pulmonary function test that one does is called spirometry, which is where one asks the patient to take a deep breath in and blow it out for as hard and as long as possible. And this is called the flow volume loop. The top part of the loop is expiration, the bottom part of the loop is inspiration. The flow volume loop in a person with an interstitial lung disease is always smaller, but of a normal shape, and this is suggestive of a restrictive impairment, where the forced vital capacity is reduced, the ratios are normal, but all the lung volumes are reduced, and the pressure-volume relationships of the lung are displaced to the right. The second pulmonary function test that is useful is a measurement of gas